Welcome on this live session for the MOOC Medical Mycology. And this session will be animated by Timothée here. He is our community manager. And our two directors, 𝐏𝐚𝐬𝐿 and Olivier, are here to answer your questions. And I would like to invite you to present yourself with a small button discussion. And so I will do it myself, and you please do the same, and please indicate your country, because it's always nice to see that there are plenty of people from plenty of countries. As I told you, don't hesitate to present yourself in the chat, but please don't use it for your questions. For your questions, it's really much easier for us if you use the Q&A button. Yeah, thank you, Richard, thank you, Case. So don't hesitate to use it. So thank you, everyone. Now we'll leave the floor to Timothée, who will animate this webinar.
Thank you, Clémentine. So welcome, everyone. We are very, very happy with 𝐏𝐚𝐬𝐿 and Olivier, our two directors, to have this session with you all. I can see that we have already 61 participants. We'll see how many people will be online today. And we hope you're enjoying this course on the MOOC platform. So we will try to already answer the questions we had on the registration form. And then if you have more questions, we'll also try to answer them during the session. If we don't have time to give answers for all questions, we'll give answers later on the forum. So I can introduce briefly myself. I'm Timothée BOYER-CHAMMARD. I'm your community manager on the MOOC. You've seen me on the introduction text, and I'm an infectious diseases practitioner in Corsica in France. And I will let Olivier and 𝐏𝐚𝐬𝐿 present themselves.
So 𝐏𝐚𝐬𝐿, please.
Hello, thank you. I'm very happy to be with you in this live session of the MOOC. I am 𝐏𝐚𝐬𝐿 GARCIA-HERMOSO. I am Deputy Director of the National Reference Center of Invasive Mycosis and Antifungus here at City Pasteur.
Hello, everybody. It's my great pleasure to be here this afternoon with you. So my name is Olivier LORTHOLARY. I'm Professor of Infectious Disease and Tropical Medicine at the University of Paris. And I am also Deputy Director of the National Reference Center for Mycosis and Antifungals. Thank you to be here.
Thank you. So I think we can start with questions. So the first question we had on the forms was, what is the best and not expensive media to screen for Candida auris?
Okay, so for that question, it's a very interesting question, because seeing the impact that Candida auris and the importance that it's been taking since many years, this yeast that can be a multi-resistant yeast, but it's important to know how can we screen it, or if there's any medium that is specific for this yeast. So normally in any culture, in any medium with a purpose of for fungi, Candida auris should be growing with any problem. The difference is that if we want to select the Candida auris, there are not a lot of media that are available. So the technique that we use for Candida auris identification at the time is using medium, using culture media. It's a chromogenic medium like ChromaGAR, for example, Candida plus, or high chrome Candida auris. And there is a selective agar, but I don't know if it's very if it takes all the clades of Candida auris. As you know, by whole genome sequences, we know that there are 4 major geographical clades. So different clades, clade 1, 2, 3, 4, and possibly a 5th one. So there are not a specific media that can be recommended at this time. For the most reliable, fast, and relatively inexpensive methods to do this is MALDI-TOF and ITS sequencing for Candida auris. So this is what we do, and in at least in France.
Thank you, Dea. And we have two more questions on Candida auris on the Q&A. So one is, do you use Sensitit for MICs, especially for Candida auris? And the second one is, what's the reference of breakpoint interpretation of Candida auris?
Okay, so for antifungal susceptibility testing in the reference center here at Pasteur, we don't use Sensitit. We perform antifungal susceptibility testing with the 𝐏𝐚𝐬𝐿 micro method. So we don't use Sensitit for that. And let me show you, because I don't have it like I don't know if I'm gonna find it now about the breakpoints, because I don't have it in mind for that. Let me show you that. If I can find it. I can tell you, for example, in Candida auris, we don't have a lot in France, a lot of isolates, but those that we tested with antifungal susceptibility testing, we can see that the values for MIC50 with, for example, the azoles, or like fluconazole, it's more than 64. Voriconazole is 0.25, and POSA is very low, also low value of less than 0.001, and isavuconazole also. So amphotericin B is in approximately 0.25 micrograms per liter for this strain.
Thanks, Dea. I think we'll have a lot of questions on the Q&A. We'll try to answer to all questions. So speaking of antifungal susceptibility, one question has appeared is, what are the accepted methods for mucor sensitivity tests? I don't know if we can
Mucor,
yes.
mucor or mucoralis?
I think it's for mucoralis.
Can you repeat the question?
What are the accepted methods for mucor sensitivity tests?
Oh, so it's the same thing that I'm telling. At least in reference centers, if you're in Europe, 𝐏𝐚𝐬𝐿 method is the one that we are using, and it's accepted. And the method, a micro method, also from the CLSI methodology.
Okay, thank you.
Also, pardon, Olivier.
I just want to add that there is no correlation at the present time between MIC values, whatever the methodology, with a clinical outcome. So that is important to remind.
There's also this e-test methodology used in the hospiitals. We don't use it in the reference center.
I think it's interesting to see that isavuconazole MIC values may be high. Also, the drug seems to work even in isolates with high MIC values.
Yeah, the main point is that we can't have the same interpretation than for antibiotics and antibiotic susceptibility testing. The clinical breakpoints are not correlated at this point.
A very useful site is to go to the 𝐏𝐚𝐬𝐿.org method. Maybe we can give the address, the link on the forum later on. So you can go and see what are the breakpoints that are already used for yeast, for filamentous fungi. It's a methodology that it's really clearly explained and everything. It's a very nice site to see the website.
Okay, thank you. Yeah, the link is on the discussion. So then we had another question on the forum, which was how to manage in resource limited settings, and we had many questions about this.
So I think first we have to diagnose fungal infections. So for that, I think it's very interesting to see new methodologies coming in the market. So rapid tests for the diagnosis of crypto, rapid tests for the diagnosis of disseminated histoplasmosis, for example. So that is one part. The second part, I think, to better manage infections in low resource areas is education. So more people will be trained in international courses, more the success will be for patients. I do not forget the importance of funding. So again, it's very important for national organization, international organization to fund and to support mycology in low resource areas. So I would say new diagnostic approaches, education, funding, and to keep essential antifungals, so shall I say fluconazole, itraconazole, and amphotericin B would be already great value for these countries.
Okay, thank you. We had also a question. Again, we go back to susceptibility testing. So we had a question about increasing resistance to micafungin for Candida. Yeah, I think you.
No, maybe Olivier can say something about this.
So first of all, I think it's important to realize that as soon as any echinocandin is resistant, all echinocandins available are in fact also qualified as potentially resistant or even truly resistant according to breakpoints. So there is no echinocandin miraculous in case of resistant to echinocandin for any kind of candida. I must say that the situation of rare yeast species, few of them are resistant to echinocandins, and at least with acquired mutation. And for Candida glabrata, the prevalence of resistance to echinocandins in France was a few months ago 3%. So we have a limited Candida glabrata resistant to all echinocandins, and we have from time to time in pre-exposed patients resistance in Candida albicans or in other non-albicans species. So no miraculous echinocandin in case of one being less efficient.
Okay, thank you. We also have a question about new antifungal drugs, which was not very precise, which was just
like that. But maybe I can share, if I can share something, maybe, yeah. Just give me a minute because I have it here. Right. No, leave it back. Oh. Wait. Can you see something here? Not really.
yes.
What do you see?
We can see your
yes, because I cannot see anything more.
PowerPoint.
Okay. Okay. PowerPoint. I'm going to put it like this and like this. Better. So we have some new, is it better like this? No. This is one that is nice.
Yes, it's fine.
This is one that is nice. So we have some new drugs, of course, besides we know that we are four main families in the antifungals, but here, I don't know why my screen is on the other side. We have the azoles and polyens, echinocandins and pyrimidine analogs. And for the new ones that are, for example, here you can see in interacting with in cell wall, like echinocandins, the resafungin. Olivier is going to talk more about those in a different way. Resafungin is in the cell wall, and then there are some others like opeconazole or olorofin that are affecting in cytoplasmatic structures, and as well as I think there's another one that I'm not saying. Yeah, and then are the others of brexafungin and fosmanogepix. So maybe Olivier, you can say something about them, and then I come from the
okay,
the mode of action.
So resafungin is very equivalent to anidulafungin. Also, it has a prolonged half-life, allowing 1 week weekly administration, starting 400 milligrams and then 200 milligrams for a few weeks. So it has been shown to be equivalent to classical echinocandin. So resafungin is a great progress for yeast infection and potentially for the prevention of aspergillosis and pneumocystis gyrovesi. Ibrexafungin, fosmanogepix act on the cell wall but are not echinocandins. Also, they act on cell wall, so that means they act by a different mechanism than blocking beta glucan synthase. When looking back to the picture of 𝐏𝐚𝐬, I think we can mention olorofim. So olorofim is active against Aspergillus and including, very interestingly, azole-resistant Aspergilli. It's not active against the Mucorales. It's active against other filamentous agents such as Fusarium and especially Pseudosporium Apiospermum complex and Lomanthospora prolificans. So olorofim, it's a great value. It's not active against yeast. So again, no miraculous drugs covering all fungal pathogens, but significant advances. And to conclude on this new agent, opeconazole will be inhaled azole therapy. So that will be a great progress. Also, other antifungals are now available in inhaled formulation, such as voriconazole, such as caspofungin, such as liposomal amphotericin B. So very soon we should have 4 major antifungals acting through inhalation.
Okay, thank you very much. We can move on to the next question, which is, so I hope we've understood well this question, which was, can wall mold be dangerous for health for patients with chest diseases?
I think Olivier is frozen.
Olivier, can you still hear us?
No. Huh? Well, in the
No. Okay.
yes.
Yes.
It's coming.
Okay.
No.
Olivier, can you hear us?
I can hear you now.
Good. So the question was about wall mold. Are they can they be dangerous for health for patients with chest diseases?
I think that wall molds are, at least some of them, especially Aspergilli and Mucorales, may be very dangerous for those with a chronic lung disease, but also for hematology patients with a profound neutropenia and prolonged neutropenia. So there are two categories of patients who should not be in contact with wall molds. Those with COPD, chronic obstructive pulmonary disease, and more generally those with respiratory insufficiency, and those who are neutropenic, at least those with prolonged neutropenia, so which provokes damage in this population.
Thank you. The next question is about vaccines. So the question was, can we expect one day to have a vaccine to prevent invasive fungal infections like histoplasmosis or cryptococcosis?
I think that for crypto, several vaccine approaches have been developed a few years ago, and now I don't know any team who are working again on a vaccine approach. We had interesting work in the hands of Françoise Dormer a few years ago, but it has not been driven to industrial development. So no major research at the present time for crypto vaccine. And for histoplasmosis, the merit was the works of George Deep in the past, who significantly studied on the histo vaccine, but unfortunately no vaccine approach is available even for phase 1 or phase 2 study at the present time. The significant approach in fungal vaccine has been on Candida vaginitis in preclinical investigation in UCLA, but not yet with human perspective.
Okay, thank you. Dea, we have a question for you about existing any anaerobic fungi in the gut?
That was a very surprising question. But yes, we have there's anaerobic fungi in the gut, but not in human gut, at least that as I know. They are found as these fungi that are belong to the different division that are the divisions that we know that are human pathogens or saprophytes, like in Ascomycota or Basidiomycota. The anaerobic fungi in the division of Neocalimastodonmycota, those are present in the gut of rumen, for example. So I don't know even the names of it. So there are zoospores. They are very different from the fungi that we have involved in human infection, or even in Mucorales or Ascomycota and Basidiomycota. They're completely different, and you should. I think this is on the course in the part of taxonomy. There's a phylogenetic tree of life, and there's are the divisions, so you can see the over there. We know that in the human intestine, but we don't have those type of anaerobic fungi, but we have, as you know, albicans, Candida albicans, the most prevalent, then following by glabrata or Candida parapsilosis, Rhodotorula, Malassezia, Saccharomyces, etc.
Thank you. And about Saccharomyces, we have a question about how Saccharomyces could help to avoid Clostridium difficile infection.
So I think it's important to realize that there is no proof that probiotic may prevent the occurrence of Clostridium or new taxonomic name I don't have in mind at the present time. So C. diff, shall I say, toxigenic C. diff, So no proof that Saccharomyces or any other probiotics work. And more importantly, there are side effects of probiotics, especially with Saccharomyces boulardii, which is responsible for fungemia in patients with denutrition and long-term central venous catheter. So be aware about these complications of probiotics in those with a fragile GI tract and those with neutropenia.
Okay, thank you. And the same participant had a question about how to differentiate Chlamydospora from yeast and from molds.
Okay, so when you do morphological identification of fungi, if you're dealing with yeast, very small number of yeast will do a chlamydospore formation. You have to find it. If you have to look for them after self-culturing in a specific medium, for example, the Candida dubliniensis or even Candida albicans. As we know, the definition of chlamydospore is just a resting cell, no, that has a thick wall, sometimes double thick wall, and very swollen. But in all the molds, for example, they are the majority of them, they are forming chlamydospores, and the way to differentiate them is only by microscopic examination and to know you have to at least know what are the types, the forms, that before in the time servos, for example, for Fusaria, some of the species, some of the different characteristics of the species included the form of chlamydospores, if they were in pairs, if we were isolated, if they were on the top, in the middle, etc. But it's not very specific. But yeah, it's by microscopic examination is the best way to see them.
Yeah, would you like to give a comment on a particular chlamydospore in histoplasma culture?
Well, they are called chlamydospores in histoplasma culture, but they are not chlamydospores. They are if you see histoplasma will be in the filamentous form, and when you look at it under the microscope, you will see thin hyphae, of course, all over septate hyphae, and one characteristic to identify this species of this genus is the formation of this macroconidia. That they are double-walled, but they are not considered as chlamydospores. They are macroconidia, and also there are the presence of microconidia in the same in this species, in this genus. Sorry.
Okay, thank you. So I think we have enough time to try to answer to more questions we have on the Q&A. So I think we'll try to answer quickly to that question. I would like to know why you did not include Mycobacterium tuberculosis in the program. So I think that is a topic on itself. I know that Institut Pasteur had a MOOC on tuberculosis, Clémentine, but I'm not sure it's still available. But I'm sure you can find a lot of tuberculosis programs online. So even if it's a very interesting topic, but it's not a fungus, of course, and that's what the participant said. He said, "I know it's not a fungus on its own right, but does it not have any co-infection with any fungal infections?" Yes. So Olivier, you wanted to say something?
Well, there are co-infections between mycobacteria and fungi, especially mold. So that can be either the colonization of TB, pulmonary TB cavities by Aspergillus, notably Aspergillus fumigatus, which may become resistant over time, but also the association, the combination of atypical mycobacteria such as Xenopy, or Xenopy, for example, with Aspergillus or other molds. And what is very difficult in case of combination of mycobacteria and mold fungi is that anti-mycobacterial agents modify the metabolism of azole therapy, and azole modify also, or may modify, the metabolism of anti-mycobacterial agents. So it's the worst situation we have with a fungal infection.
Thank you. So it will be I take questions as they come. So what are blood antigenic lab tests approved as diagnostic for fungal invasive infections? I don't know if you want to answer. I think we can also I will put the link for EORTC criteria. I don't know if you have any more comments, Olivier or Dea.
So the question, if I'm correct, is blood antigenic lab test approved as diagnostic for fungal invasive infection?
Yes.
So we have a non-specific antigen approach, which is beta-D-glucan, which is interesting in some circumstances, at least for diagnosis and not so much for follow-up. So the most interesting infection for beta-glucan detection is a pneumocystis jirovecii infection in both HIV and HIV positive and HIV negative patient. So we have Aspergillus galactomannan since 1995, which has been associated with diagnostic revolution for aspergillosis, especially invasive aspergillosis among immunocompromised patients. And now we have new approaches with cryptococcal antigen detection with LFA, which is much better than the agglutination test we had in the past, and even better than ELISA. And there is a major development by various approaches and companies of histoplasma antigen detection. So yes, we have now, shall I say, 4 antigenic approach for diagnosis of invasive fungal infection.
And thank you. We have a new question about beta-D-glucan. So is the determination of beta-D-glucan levels a useful test for monitoring the potential risk of a mycetoma recurrence in a patient who has previously undergone amputation or surgery?
I'm very honored to have this question because it's the conclusion we made in a paper in PLOS neglected tropical disease a few years ago, where we looked to the contribution of MRI and beta-D-glucan detection for the prediction of relapse. So yes, beta-D-glucan is very, very interesting for mycetoma management. Also, so we have to acknowledge, unfortunately, that beta-D-glucan detection is not available in most of the fields where mycetoma are present, at least in Africa.
Thank you. Still about antigen testing. What is the performance of serum or urine antigen diagnostic test for the diagnosis of histoplasmosis and the problem of cross reactions with other fungi?
Yeah, you want to say something, or?
You can say it. The only thing that I can comment is that diagnosis for histo serum and urines are useful, and that are the question was the sweet. What is it, Timothée?
The performance of serum
and the
or
cross
urine
reaction, right?
antigen and the cross reaction with other
And
fungi.
the cross reaction of antigen, right? for example, the 𝐏𝐚𝐬𝐭𝐞𝐮𝐫 of Aspergillus with histoplasma. But Olivier, please expand.
I think it depends on the type of antigen we deal with. For crypto, we work on crypto new diagnostic approaches in Africa, and we were able to show that using new cryptococcal antigen tests, we had a false positive in urines. So I would not recommend at all to use urine for antigen detection. Why, as they have said, since the beginning of the histoantigen story with radioimmunoassay first, then ELISA, then now much more easier test to perform, urine is very, very interesting. So I would say urine for histoplasma antigen and serum or plasma for crypto antigen and CSF, of course.
Thanks. I think we don't have any more questions about antigens. No, yes, sorry.
No, go ahead.
We have a question about biosafety. So what's the biosafety level required for mold sensitivity? So what is the biosafety level required for mold sensitivity testing?
The biosafety requirement, if I understand the question, is depending on your risk class. Yes. of your fungus. What do we have to do if it's a class 2 or class 3? So it's for antifungal susceptibility testing or for any other manipulation of the fungus. If you are dealing with class 1 and class 2, then you have to manipulate in a laboratory of class 2. So if that's for almost the majority of our fungus. But if you are dealing with fungi that are class 3, then you have to be in the P3 confinement laboratories specific for this fungus. So yes, antifungal susceptibility testing, you have to do it under PSM and hoods, sterile hoods, etc. But it's not. It's always in P3 confinement lab.
Yeah, you want to add something on the dimorphic fungi and black molds?
About
precautions of
yes, for the cultures. So yeah, I think what Olivier is saying is that when we receive cultures to analyze, be very aware that if you're receiving tubes with slants, with having white cultures, for example, and having a brown reverse on your tube, and also, of course, always having the clinical information for this culture. Be just aware that it could be you could be dealing with an histoplasma strain, for example, that it's an endemic fungi and dimorphic one that should be manipulated, of course, not in a P2 level laboratory. So this is one of the things that you have to remember. Also, if you imagine a black fungus that are isolated from a brain abscess, etc., and I think Olivier is going to make some comment about this. For example, Cladophillophora bantiana, then if you don't know what it is, be very careful when you receive this kind of melanized fungus coming from brain abscesses, etc., to be at least manipulate it on the hoods that are specialized for getting this really sterile, and better if you can do it in a PD2 plus or P3 laboratory.
I think there are 3 black molds which are very dangerous for patients, especially because of specific neurotropism, so responsible for cerebral infection. These are Cladophillophora bantiana, as they are said, but also 𝐏𝐚𝐬𝐭𝐞𝐮𝐫 𝐌𝐎𝐻𝐬 in Morocco now, in Emirates states, in Pakistan, in India, in Afghanistan. So all these areas now, we know that 𝐏𝐚𝐬𝐭𝐞𝐮𝐫 cases can be responsible for brain abscesses, and more commonly, also still rare in France, is 𝐽𝐿 with various species, 𝐽𝐿 which has neurotropism as well. So as soon as there is a potential black mold infection, be very cautious.
Exactly.
Okay, thanks. Then we have a question about fungic balls, sinus fungic balls. So the question is how to identify a fungic ball from surgery for chronic sinusitis. It's more a diagnosis lab question. I don't know if you can see the question in French, Olivier.
Where is it?
Out there. So in French is bonjour, comment faire l'identification d'une balle fongique issue d'une pièce opératoire pour sinusite maxillaire chronique? Faut-il broyer la pièce opératoire et faire la culture?
So certainly not crushing the material, because we know that there are false negative detection of mucorales as soon as the biopsy, the sinus biopsy has been crushed. So don't do that, and it will be much more interesting for diagnosis. Leah, you want to add something?
No.
Thank you.
Fresh, unbrushed material.
Yes. Then there is a question about antifungal combination to treat resistant fungal infections.
Mm-hmm.
Well, this is a question. Is there? The question is there any antifungal combination to treat resistant fungal infections?
So there is a famous combination of antifungal therapy, but which not address resistant isolates, which is a combination of high dose or liposomal amphotericin B in combination with 5-FC against cryptococcal meningitis. So that is very clear. There is no major data showing the potential interest of combination therapy with echinocandins. What can I say more? So there is now, to come back to black mold infection, we have evidence from data under preparation in the National Reference Center of the interest of triple combination therapy for Cladophila bantiana brain infection. So the combination of liposomal amphotericin B, 5-FC, and posaconazole. So it's a niche, but it's interesting to see that there are more evidence than crypto alone now for potential interest of B or triple therapy.
Thank you. And another question about treatment is why isn't potassium iodide the initial treatment of choice for sporotrichosis in developed countries?
Why? Sorry, I didn't catch.
Why potassium iodide is not the initial treatment?
Because it's much more easier and safer to use itraconazole at a low dosage. So potassium iodide can be still given in case of lack of itraconazole availability, but GI tract disturbances are observed with potassium iodide, and shall I say, itraconazole is much more efficient and rapidly active for patients.
Okay. Then Dea, maybe how to determine the sensitivity of dermatophytes to antifungal and when to do it?
This is for dermatophytes. I don't have any experience because we don't do dermatophytes. We don't we don't receive them because it's not an invasive mycosis, at least for some of them. But 𝐏𝐚𝐬 determination of antifungal of dermatophytes is used. Just the method changes a little bit, but it's done in that. And I think it's important to do it when there are when there's some mutations in terbinafine. So Olivier, maybe you can comment on that for the new trichophyton 𝐴 and all that. But
yes,
I'm not the experience in that.
We start to see in France, especially in dermatology centers, of diffuse dermatophyte infection due to trichophyton 𝐴, so corresponding to very specific genotypes which are present in Bangladesh, in Sri Lanka, in Indian continent. So we see patients coming from this area with diffuse dermatophyte infection without any immune deficiency, and these patients are difficult to treat first, and for that we and others have developed a voriconazole cream, which provides very encouraging data. And as they are said, this fungus Indotinae can be resistant to terbinafine. In that case, we should give prolonged azole therapy, knowing that azole can be inactive because of associated resistance. So it's a new challenging clinical issue and therapeutic issue for patients coming from Indian continent especially.
Okay, thank you. We have a new question for histoplasmosis diagnosis. Which antigen detection platform is better, LFA or ELISA?
It's under investigation.
Yeah.
Thank you.
Timothée?
Yes.
I saw this question before, the one of the combination antifungal about Aspergillus species. I don't know if you missed it or not. Aspergillus species at molecular level. Diagnosed? No?
I can't see it, but yes,
okay.
Go ahead.
Okay, but Keith might, I think. So if I understand the question, the way he wanted to say it is that how do we, at least at my experience, how to identify the different Aspergillus species at molecular level. So remember that when you do identification of a fungus, at least of a mold, it's very important to have the polyphasic approach. So the morphological is it's vital, and of course the molecular level to get to the species level. So for Aspergillus, they are what we use for all of them is the beta-tubulin marker and the calmodulin marker. We don't use ITS for sequencing, even if you can do it, and you will get at the genus level. But it's important to know that this is not as good because they're not very resolutive for all the species that are in the genus. So better to use beta-tubulin for example, Aspergillus section fumigati, and then all the calmodulin that serves for all the other species also it's very good. And sequences are available in public databases. And remember that molecular level, when we are doing sequencing and we're blasting and we're doing similarity researches in databases, you should be careful to use curated databases. And if not, go and see what the sequence on your blast that you have in your first hit. Is the sequence good enough? It's from a publication, and you will see if it's good. You have to go deep, and not only because it's 100% identical that it's going to be the good response. So that's what I can say about the identification at molecular level, at least for Aspergillus, but also for the majority of the mold.
Okay, thank you. There is a more technical question, as it said, how much time is necessary for the KOH to take effect on the sample, like nails, in order to correctly observe the yeasts and Malassezia?
I don't know about the time, how long you have to put the KOH. We don't do that because we don't receive biological samples at the reference center. So we can address this question to the hospital mycologists, so they can give us a really good answer, I think. So and yeah, I don't have the answer for that.
Yes, and we'll give the answer on the MOOC on the MOOC discussion.
Yeah.
Thank you. There's one more question about any harmful fungi obligatory declared to health authority.
So I think it's clearly dependent on the country. So there is no international recommendation to mandatory declare to health authorities. For example, in France, public health authorities have asked us to collect Candida auris isolates and to declare infections due to this emerging and very difficult to treat species. And the other recommendation we have in France is to declare major outbreaks to health authorities. Also, other European countries may not do that. So very country specific.
Yes, thanks. We have two questions about Trichophyton indotineae. One question is there a molecular assay that we can use to rapidly identify this species, and a specific assay? And then we have a treatment question about it, about the use of, do you think that the use of topical cyclopyrox associated with voriconazole could be a valid solution for Trichophyton or recalcitrant dermatophyte infections previously treated with itraconazole and terbinafine?
So my knowledge of identification, Trichophyton indotineae, as other trichophytons, you can identify with ITS or beta tubulin marker. So that's the only answer that I can give you, at least at molecular level. And Olivier?
To answer to the potential use of topical formulation, I think again we developed with pharmacists from Necker Hospital in Paris a new formulation of voriconazole, which appears as a cream. So voriconazole cream 2 times per day for weeks can cure terbinafine resistant Trichophyton indotineae recalcitrant to other antifungals. So how to prepare voriconazole cream has been the matter of one publication in International Journal of Antimicrobial Agents. We can provide that in the post forum.
Sure. Thank you. Well, there is I think a complicated question which is there an appropriate animal model for studying lymphangitic sporotrichosis or cutaneous disseminated sporotrichosis?
I think the worst situation with sporotrichosis is cat-associated sporotrichosis in Brazil and now invading surrounding countries. So I would not ask for a cat being an experimental model for sporotrichosis, but it's a very strong association and unfortunately predictive of human infection. And if you are HIV infected in Brazil with contaminated cat with sporotrichosis, you may die from disseminated sporo, which is experimental, shall I say.
Thanks. There's a new, more general question about antifungal resistance. I don't know if you can comment it. Should we fear the emergence of resistant strains today, as it's the case with antibiotics? I think we've already.
The answer is no. The answer is no, because there is no interspecies dissemination of resistant support, such as plasmid for bacteria. So there is no evidence of antifungal resistance being as a big problem as antibiotic resistance. I would say just two points to moderate what I said. For Aspergillus fumigatus, we face more and more during a chronic Aspergillus infection, or even in a neutropenic patient or any kind of immunodeficiencies. Now we find more and more Aspergillus fumigatus resistant to triazoles. And the second point is multiplier resistant Candida auris infection or Candida emuloni complex, which are potentially source of outbreaks with a resistance to azoles, amphotericin B, and sometimes echinocandins. But fortunately, it does not reach the antibacterial situation.
Thank you. We have a question about Malassezia. So again, how can we process with Malassezia cultures? Which media, which conditions?
Alors, Malassezia needs lipid to grow, so and you have to there are specific media named Dixon media, which you can add some between 20 to 80, so Malassezia can grow. There is only one Malassezia, the one species of Malassezia. It's named Malassezia pachydermatis, and that's the only one that can be cultivated in a culture, on Saburo agar. So that's the thing. We can put I can put the Dixon recipe of that if it interests Larissa, right? Larissa time. So I can answer that.
Thanks. I think we'll have to close the session, Clémentine, right?
Yes.
So thanks a lot, everyone, for your participation for this session. You know, you can still ask questions on the MOOC discussion platform. We'll try to answer it. And thank you very much to Dea and Olivier, and to Odile and Clémentine for the support.
Thank you very much. Bye-bye, everyone.
Thank
Thank
you.
you.
Thank you, all of you.
Bye.